it's great to be here. I'm Laura Neilson, and I'm just going to talk to you about focused care, which is a model that we've developed in Manchester, and we started it in the practices that I run, and now it's spread to about 70 odd practices in Greater Manchester. So it's across quite a lot of PCNs, and it's aimed at practices that are deep end practices or in the most deprived, or whatever way you want to cut that graph found. It's okay. So this is Fitton Hill, which is where I lived for a long time and where we opened the first practice. It looks really green from the sky. It's less green and a bit more grim at ground level. But anyway, there's a drone picture that makes it look pretty. So Fitton Hill is in Oldham, which is on the edge of Greater Manchester, and it was a kind of mill town. It's now got quite a lot of bargain shops and betting shops and quite a lot of chippies, and it does now have a cinema, which is cool. And our practices, this practice is just on this estate, which is just south of the town centre. So I don't know if you can spot the panda hiding in this picture. There is one there, honestly. You haven't so some clever clogs have found the panda. Oh yeah? No, there's a few faces looking like she's mad. We know that, that's fine. So the panda is on the front row, for those of you who can't find it. And once you've spotted the panda, you can't not see the panda. But amongst all the snowmen, it's quite hard to find the panda. And for me, patients who are focused care patients are a bit like the panda. When you start spotting them, you start seeing them everywhere in your practice. But to start off with, they don't kind of fit the pattern recognition that we're meant to be doing and that we're trained for. So we talk about focused care being a failure to thrive. So we nicked it from paediatrics. All the best ideas are nicked. I love failure to thrive as a concept. There's no blame. There's no diagnosis. There's not reams and reams of guidance on it. It's just you look at a patient and you say, this isn't working, and what is going on? And obviously in paediatrics, it could be the 1 in a million metabolic thing that we've never heard of. It could be attachment, it could be feeding issues, it could be a whole load of stuff. But we don't jump to saying it's the metabolic condition that no one's ever heard of. We unpick it. And we applied that methodology to adults and households in primary care. So they might be the patients who come to you and the story doesn't add up. Or it might be they've got 101 things going on. Or it might be that they don't fit services. So particularly where we are, the thresholds for other services keeps going up. And these patients end up with kind of no real pathway. So we talk about health inequalities being failure to thrive, multiplied by barriers to universal services, and then exacerbated by social determinants. So if we start thinking of health inequalities, those component parts, how do you unpick them? So when we take focused care into new general practice, I go and talk to the doctors, and there's broadly a couple of practices. There's practices that are drowning, where they're like, everybody is so difficult, we just can't cope. And that's not true. Not every patient is a panda. And then there's practices that say, no, everything's fixed, but our PCNs told us we have to have focused care, so you may as well come in and we're actually hunky-dory and fine. So it's a slightly different way of kind of approaching it. But I asked all the doctors and the nurses and the receptionists, who was the patient that kept you awake at night? And in primary care, it's not the medically interesting, because generally they go somewhere. They're in a hospital system. It might be slow, it might crawl along, but they are in a system. And Professor Boffins is going to look at them at some point, and they will come out with a plan. What keeps people awake at night is the patients. They just can't quite articulate what's going on, or they don't fit anywhere. When I was a medical student, I was taught to clerks. It's when you go and see a patient and you assess them, you have to ask millions of questions that you have to learn off rote. And then you come back and you present it to a consultant. When I came back to present my patient to the consultant, I told him everything, when he was born, where he went to school, what the cat was called, what he had for dinner last night, how much he smoked, how much he drank, the argument he had with his wife. I knew everything. And this consultant, who was quite posh, he went, Laura, that is remarkable. The thing is, you have not mentioned the patient is yellow. And I hadn't mentioned the patient is yellow because I didn't know the name for it. I knew he'd asked me loads of questions about it, and I didn't know what to do next. And when we look at patients who are complex in poverty, we know that they're yellow, but we don't have the words, and we don't have a plan. And because of that, a lot of us duck it. and there's a system we duck it. So focus care is about saying all those patients who are yellow, we're going to put them in a process. And the other one we look at is who's disengaged. So it's a great time of year at the moment, end of QOF year, because you suddenly see the patients who we haven't seen forever. They're flashing yellow triangles galore on your computer screen. And every year we go through our list of people who we haven't engaged. And every year we find someone who's, when we knock on the door, living in squalor, something's gone completely wrong. So who is not engaging is a really interesting proxy. So focus care is a little bit like Call the Midwife, but without the uniform. I think some of them would like the hat, if I'm honest. But they are people who are trained, they're Band 6 workers, either in health or social work or youth work or probation or housing or something that's frontline. They've normally got at least 10 years experience of working with the public. When they come to interview, we look for the bit where they say, well, I could have been a manager, but I don't want to manage people because I love casework, or I get frustrated in my current job because I know they just need that form filling in, but I can't do it, or I get frustrated because I can't do X, Y, Z. So there's some element of frustration, there's an element of autonomy, and there's an element of being sensible. And then we train them in kind of lots of the areas that they didn't come with. So if you've trained as a nurse, you know very little about housing. So we talk about housing and benefits and immigration. They get this kind of very broad kind of training package, really. And then they go and see patients at home, and we only ever deal in households. So trying to unpick a complex family where you're dealing with one person is just like, it's like trying to unpick one knot without looking at the necklace the other way around, you know, when your necklace got all. So you have to deal with households. And we make a plan, and it's with the patient and their family. And often the plan is not what we want on the plan first. So, you know, the QOF box is going diabetes, smears, MMR, hypertension, get a foot check. And if you walk into those households and you go, well, actually, I know that you've got no carpet and no heating, and you've got some violence in your relationship problems, and you've got this pile of letters you're not opened, and your kids aren't going to school, but actually, what I really want to see is your left toe, because I want to check it's not fallen off for a diabetic check. They kind of don't go with you. So it's going the other way around. And what we found is that when we unpick this cohort, about between 6 months and a year, the health outcomes start coming. So they don't come early, but they come late. They come as a byproduct. But what we also see here is increased satisfaction from our GP team. We've got a pathway for people where there's no pathway. We managed to make other services bend, so you can suddenly gather the information for safeguarding, for housing, for trafficking, for domestic violence, all those services that we struggle to do. And none of that is going to the GP. That's all being dealt with by the focus care worker. So we talk about it being the art of the possible. This video, which hopefully will play, is Danielle, and I want to play you this. She's a patient at John Street Surgery. And we opened underneath the surgery in the basement a drop-in for homeless families. We opened it about 3 years ago, thinking we wouldn't be very busy. So there's 2 things I want you to learn about from this video. One is that homeless families is a massive problem that we need to systematically tackle. And this is an amazing story of what can be achieved when we manage to get our health ducks in a line in the context of a bigger system. Is that right? So have a listen to Danielle.
Angie came into my life around January 2021. I was born into quite a big family. There's like 16 brothers and sisters all together. There is some issues with the family. My dad was a drinker. I'd lost my brother to an overdose. My mum really wasn't like the best of mums. She was abusive to us, mentally and physically. When I was 17, I got into my first proper relationship, and he was violent to me. He broke my nose on several occasions, just always used to hit me and things. So I moved back down to Oldham to try and better my life. After about a year of working, I fell pregnant with Clayton. I was sofa surfing at the time. I was living with my sister at this time. The pregnancy was vile. I was sick every single day up until I gave birth. I was even sick after I gave birth. I moved in with my dad. He just ended up losing the house due to rent problems. He couldn't afford it. Before we even got evicted, the house just got absolutely destroyed. We didn't even have a door on the door frame. Windows were smashed. We was left with nowhere to go. I wasn't safe in that house. I couldn't have stayed there with Clayton, and that's when I presented myself as homeless. We got put into a homeless hostel. It's a bit scary. First day, not knowing where to go. Angie and Roz helped me to get to the place where I was, so I knew where I was going.
How old was Clayton when you went into the accommodation for the first time?
He was just over 1. We had all the screenings done in pregnancy. There was no indication that Clayton was going to be disabled. He just wasn't meeting milestones, no matter how much he tried. He wasn't strong enough. He got diagnosed with Merzbacher disease, a rare condition that affects the myelin sheath in the brain. Set messages Clayton doesn't receive. His brain could tell him to pick something up, but then the only message he might receive is just to pick the hand up, not actually bring it to himself. He can't bear weight in his legs. He has hypotonia, which is low muscle tone. He's registered blind. He has spasticity in his legs, global developmental delay.
How did you feel about the genetic result that you were given?
I was more angry more than anything. I'm one of 9 kids. Why just me out of all them 9 kids? But then I started to see the good side of it too, because we got told that Clayton might never walk or talk. Even though he can't do these things like normal kids, he is still showing determination to get. Yeah, he's so happy. When I got the diagnosis, I said to Angie I wanted to be sterilised, because it is a big job to be sterilised, and there's so many life changes you could want kids in the future. I have stuck to contraception in case I do change my mind. I found it difficult, and Angie had to support with the implant and things and depot and keeping on top with it.
Can you list for us the number of services that you think you've been involved with to this point, because there's only 2?
So we had the health visitors, midwives, GP. Roz was classed as focused care. Angie, community nurses, occupational therapy, community occupational therapy, neurology, paediatrics, genetics, the eye hospital. Even though there is quite a few people involved, quite a few people have also left us because we're just progressing and doing well. There's not a lot that they can help us with. I feel like I have more of my own voice now, so I found the confidence to stand up for Clayton and his needs and just get us everything that we're entitled to. Clayton has special seats. He needs upper trunk support, otherwise gravity will just pull his body back down. He has extra help in nursery. He has a one-to-one support worker that comes in and helps. He has a visual impairment nurse that comes in. Sarah also helped to get his EHCP plan. There's a charity called Victor. They've sent Clayton sensory boxes. We get access to a lot more support. I want him to have everything that I never had, so that's a big part in everything that I do for him, pretty much.
What's really amazing about it is that she's a story that could have been so different. She could have ended up on safeguarding. She could have easily had that child taken from her. She could have ended up in a whole different situation. She's got contraception. She's not in a relationship at the moment. She wanted to be sterilised. We persuaded her not to be sterilised, just to have long-term contraception because she's very young. And she has also just started to apply for college. So it's an amazing story of what you can do in normal primary care. We're not specialists, we're not anything, what are we? We're just a normal bog standard primary care team who have managed to embed focused care, and she's a panda. But she's a panda that you'll all have in your surgeries. And when you see them, you can't stop seeing them. So just in summary, it's band 6. At the moment where we are, it's funded through ours funding for band 5 and then topped up with the ICB, which is real fun every year to go and beg for top-up money, but we do. We do this induction program and training program, and we do supervision. So supervising these autonomous roles is really important. You can't just fling people out, give them a phone and tell them to go and unpick complexity. And then we're offering partnership arrangements with different practices or PCNs at the moment. So we've been very novel and said gold, silver, bronze. But basically gold is where we employ people directly and take all the employment risk. Silver is where there's employed locally and we do a lot of wraparound. And bronze is where we come along for a year and we either do a training program alongside an existing team that wants to do focus care but isn't quite doing it, or we start it from scratch. So if anybody is interested in finding out more, then you can either come and see us or we can talk online. But we've been doing it for about 10 years and it's consistently the thing that keeps our primary care teams functional. And what was really encouraging is that I went to see a practice a couple of weeks ago in Greater Manchester who are like politically opposite of me, like very profit-driven, slick, big practice. Do you know what I mean? Like, anyway, Focus Care went into their practice and they asked to see me and I went, oh no, this is never going to go well, is it? But I went and they were absolutely thrilled. Even within that practice, within that team, they recognised it was taking a cohort of patients that were struggling in primary care, the inclusion health patients that are there in every practice, and making them have better care. They were actually really pleased because they'd seen an increase in their QOF and their PCN performance indicators from those patients. So they were happy to tell me that the project was worth doing. So that's good. So this is just some comments from the patients. And we can do questions afterwards. Is that all right? Thank you so much.